Good morning, everyone. First of all, I wish to thank all of you for your presence in this symposium. Today, I will try to show the utility of ultrasound in planning the vascular access, particularly dealing with a very hot topic currently disputed among experts, the effect of routing mapping evaluation prior to vascular access creation. Well, in recent years, we have witnessed the incorporation of portable ultrasound devices in clinical practice. This has been very useful in planning the access creation, but also has motivated the need to well define the indications for their use in daily practice, mainly to determine its convenience or not in all patients undergoing surgical access creation. As we all know, physical examination of the arterial tree in the upper limb consists in the assessment of the presence of quality of distal pulses, brachial blood pressure, and the performance of an Allen test. All these give us the information about the functional patency of arteries and give us signs of suspicion of the presence of significant stenosis. In addition, the usual venous examination, venous physical examination, is based on the evaluation of the cephalic and the basilic vein and their properties, the diameter, continuity, and distensibility. But this kind of examination does not allow an accurate quantification of all these parameters. Well, what can duplex scan give us better than physical examination? First, in the arterial system, ultrasound examination can accurately measure arterial diameter, which is a main prognostic factor in the future access. We can also evaluate the arterial wall morphology, assessing the presence of arterial calcification and the intima media thickness, factors related with the success of the fistula, as well as the hyperemic response related to the functional status of the arterial tree in that limb. The US evaluation in the venous system can help us to determine the patency, the venous appearance and suitability for cannulation of those veins, the quantification of diameter and distensibility of the vein that we will use to create access is also a major prognostic factor for the patency of the fistula. And finally, the analysis of the spectral Doppler waveform brings us information about the functional patency of the central veins. The advantages of ultrasound mapping regarding physical examination seem clear. If we take a look at the literature, we can confirm this. In this line, in 2002, Parc found these good outcomes after ultrasound use. The same year, Robin saw this advantage in the form of changes he found changes in the clinical plan, increased use of autologous accesses, and fewer unnecessary surgical procedures. And the last study I will mention was published by Wells in 2005. He found a positive contribution of ultrasound in half of the patients with insufficient clinical examination. So we can say, yes, of course, ultrasound mapping is useful, but we must remember something. All these findings are only true in patients with insufficient clinical examination. This means that we are talking about only about 25 to 50% of all patients. So what can we say about patients with favorable physical examination? Several authors have tried to answer this question, as we can see in this slide. At least 5 randomized controlled trials and 3 meta-analyses and systematic reviews have been published to determine this. The first published in 2001, McManley studied 124 patients with distal fistulas, comparing ultrasound with physical examination, regardless of whether the physical examination was favorable or not. He found better outcomes in the US group with statistically significant results, 94% versus 75%. The main finding in the failing fistulas was the presence of chronic thrombotic changes in the venous wall. I think perhaps this is a very strong study that presents the major problem of monitoring. Just one control is down and gives information only about the immediate failure. After this, Nursal in 2006 randomized 80 patients between physical examination and routine mapping, evaluating immediate thrombosis in the first day, early thrombosis at 1 month, primary and secondary patencies. And they found a trend to lower rate of interventions in the ultrasound group, but this was not statistically significant. I think this study is also very important because it reproduces quite well the circumstances that we found usually in clinical practice. This study is perhaps the less known because there is no English translation as you see in this slide. Thank compared a routine US group and physical examination, and the outcome was the 6 months primary patency rates were of 90% in the US group and 80% in the clinical group. The problem with this study is perhaps the high risk of bias associated with in this study. Well, perhaps the most important study I think is published is this one by Ferring on 2010. Why? Because it has the greatest number of patients, 218, and the lower risk of bias. Also, it's the first trial comparing routine and selective mapping directly. They found clearly better outcomes in the routine ultrasound group, with the significant differences in immediate failure and assisted survival, but they were not significant in primary failure and primary AVF survival. These authors think that this may be because ultrasound perhaps improves AVF patency, but not its maturation. Also, they establish as 12 the number of ultrasound examinations needed to prevent one AVF failure. And the last trial published to date is this one by Smith at 2014. Like Ferring, they compare the selective and ultrasound group. And they found better outcomes in early thrombosis at 30 days, but they did not found any significant difference. Well, this has been the trials till now. And now let's see how about the reviews. The first is the systematic review by Wang on 2013 with the studies of McManley, Nursal, and Ferring. Total 402 patients. They studied the ability of the fistulas to support hemodialysis and found significant better outcomes in the ultrasound group, as you can see here, 81% versus 69%. Last year, COSA published this review with the Cochrane collaboration, with the studies by Thang, Nursal, Ferring, and Smith. The comparison was between routine ultrasound and standard preoperative care, including physical examination only and selective mapping. And they found no differences in any statistic parameter. This is the last one. This is a meta-analysis This is the only to include all the five randomized controlled trials, McManley, Zhang, Nursel, Ferring, and Smith. The authors found favorable rates in immediate failure for routine ultrasound, and also when they compare routine versus selective mapping. This one and this one. As we have seen, the main evidence is provided in these 5 controlled trials. But there are two problems have to be raised. First, the great heterogeneity found between those studies. We have, at first, three studies that compare routine mapping versus physical examination, and only 2, Ferring and Smith, who compare routine and selective mapping. We also see a difference in the criteria of both routine mapping and physical examination, and in the outcomes in the different studies. Finally, as we can see in this figure, most presented a high risk of bias, which implies a low quality of evidence. So what we should do? There is little doubt that patients with an insufficient physical examination can benefit for US mapping. But if we have a global look at the available evidence, we cannot definitely conclude that the advantage of selective US ultrasound mapping in patients with favorable physical examination. And what are the advantages of routine mapping? First, eliminates the surgical exploration of the vessel, because it allows to know the characteristics of those vessels before surgery. Second, it's very useful in the detection of pathology that cannot be seen in a basic physical examination, as the presence of post-phlebitic veins, central venous stenosis, and the detection of arterial proximal stenosis. And finally, perhaps the most important, I think, gives the chance for a more efficient use of venous bed. The disadvantage are a worse management of health resources, because it increases the number of required examinations. Also can increase the complexity of these explorations. And finally, some patients can delay, in some patients, it can delay unnecessary the decision making. Well, as the evidence is not conclusive, let us look at the main clinical guidelines. In the last edition of the DOCI guidelines, recommend routine ultrasound. But there is an important thing here, because they were published in 2006. We should bear in mind that 10 years ago, only the study by McManley has been published, and the recommendations were mainly based on criteria of good clinical practice. Currently, although the evidence is significantly greater than 10 years ago, it remains inconclusive, and decisions regarding preoperative studies should be based on both evidence and good clinical practice. US mapping gives us a global vision of the patient's venous capital. It allows us to make a roadmap of the present, it's very important, of the present and future vascular accesses. In our opinion, the decision may be related perhaps on the availability of the use of portable ultrasound devices. If physicians have access to them, US mapping represents only a moderate increase in time and does not cause delays in making decisions. What are the contrasts of the use of use devices? And finally, that's why we agree with the last edition of the Spanish clinical guidelines developed by the multidisciplinary team, GEMAP, that recommend routine preoperative ultrasound mapping for the creation of all vascular access. And perhaps on next years, I hope in next years will be more studies, more trials available to try to determine this question. But actually, I think that's all the evidence that we have. Thank you very much for your attention.